Since I can't be in class with you today, I don't want to miss a day because we're slowly running out of time. So I'm going to give you a lecture through this. It'll kind of be like I'm in class, but of course I'm not really there. If I make it back to class by Thursday, then we will do the heart dissections that I promised you we'd get to do today. Unfortunately, that's just not going to happen. So for this lecture, I'm going to go over 3 different things. We're going to talk about the motion of the heart, actually how it works. We're going to do a little bit on vital signs, and then I'll come back to that when I see you guys next. And then the last thing I'm going to do is going to be the fetal heart, which is, for what I'm going to have you know about it, isn't going to be that much in depth. So to start with, let's talk about how the heart actually works. So motion of the heart. The very first thing that happened is blood returns to the heart and fills the atria, putting pressure on the AV so they are forced open. Second thing that's going to happen is the ventricles begin to fill. Third thing, atria contract, forcing additional blood through the AVs into the ventricles. Number 4, ventricles contract, forcing blood against the AV, which then causes number 5, the AV closes. Sixth thing, papillary muscles contract and chordae tendineae tighten to prevent AV flaps from everting, so going back into the atria. Seven, as ventricles contract, pressure increases against SL valves. This then causes the SL valve to open, Then, very last thing, as ventricles relax, blood flows back from the arteries to close the SL. And that's the basic motion of the heart. It can happen on both sides of the heart, so it doesn't matter if I'm talking right or left. As the blood comes in from the inferior vena cava and the superior vena cava into the right atrium, which then flows down into the right ventricle, it's going to happen the same way as it does for the pulmonary veins when they bring blood to the left atrium and that flows into the left ventricle. It does not matter. So just to go back over this really quickly, it doesn't matter which side of the heart I'm talking about. It's going to occur the exact same ways on both sides. So blood returns to the heart. This could be from the superior vena cava, the inferior vena cava, or the pulmonary veins. It doesn't really matter. And it fills one of those two atriums, therefore putting pressure on that specific AV valve. So it could be the tricuspid or the bicuspid. It just depends on what side of the heart you are talking about. So this, when I say AV, remember I'm talking about the tricuspid or the bicuspid. When you put pressure on that, you're going to force them to open. When you do that, the ventricles begin to fill. The atria are going to contract, forcing more blood through the AV into the ventricles. The ventricles contract, forcing blood against the AV, causing whichever one you're talking about, tricuspid or bicuspid, to close. The papillary muscles contract and the chordae tendineae tighten in order to prevent the AV from going back into the right or left side of the atrium. So the way that I had it drawn is if this was the kind of inside of your heart. I'll do the tricuspid just because I was thinking about it. Your chordae tendineae, which are going to be connected to your papillary muscles here on the side of your heart, are going to prevent your AV valve from going back in this way. You want to keep it tight. You don't want it to go back and like invert itself back into the right or left atrium, depending on which one you're talking about. As ventricles contract, the pressure will build up, and that'll eventually open the semilunar valves, depending on which one you're talking about, whether or not you're going into the pulmonary artery or if you're going into the aorta. You'll have your two different ones. Then, as the ventricles relax, blood will actually come back a little bit out of your arteries, whether it's the pulmonary artery or the aorta, and close down that SL valve so that you don't have any serious backflow. Okay, so that's your basic motion of the heart. Doesn't matter which side of the heart I'm talking about, right or left, it's going to happen roughly the same way. Now from this, let's talk about your vital signs. There's several different places that you can look within the body for vital signs. One of them you can do just simply by looking at a person, and that is going to be your skin color and your temp. If you'd seen me the past 2 days because of the stomach bug I have, I am deathly pale and I've had a temperature off and on for the past couple of days. Second thing you can do in order to get a vital sign is you can look at pulse. This is essentially going to be your heart rate. And a lot of people will abbreviate this as HR. For most people, your heart rate should be between 60 to 100 beats per minute. BPM means beats per minute. Most people are going to fall in that. There are a couple of different places that you can look to find your heart rate. One of them that you can look or feel for are any of your common carotids. Find one and you'll be able to figure that out. You could also use your radial arteries in your arm. You could use the femoral arteries in your legs. You could use, and this one would be a little bit less, that's why it's at the bottom, your brachial arteries. Or you could also use your facial arteries. You have a couple of big ones up in your face that you could also use. Most people, if you're going to feel for a heart rate, you're going to use these two. If you've ever seen anybody take pulse or you check for pulse, you almost always see them do it up in the neck, so that'd be your carotid carotids, or you're going to see it down in at your wrist, and that's going to be your radial arteries. Notice on here, I've only talked about arteries. You only ever use arteries in order to get a heart rate because you'll feel the pulse of blood coming out of that left side of your heart. You don't want to use veins because veins are just trying to get blood back up to the heart so that it can go back to the lungs. So you don't get anything from a vein. You want to get everything from an artery. The third thing that you can look at in order to do vital signs is your respiratory rate. If you are healthy, you should have it around 12 to 20 breaths per minute. The final thing that you can look at for vital signs is going to be blood pressure, or your BP. If you're going to do this, you're going to need two different things. You're going to need the stethoscope and you're also going to have this lovely word. Which I, for the life of me, cannot say ever correctly. This is also known as the blood pressure cuff. But I'm going to give you its nice technical name, which I've never been able to say. With the blood pressure cuff, this is going to be measured in millimeters of mercury. If you've ever played with one at the doctor's office, then you probably already know that. The way this usually works when you're doing blood pressure, for most people, you should be 120 over 80. And that would both be in millimeters of mercury. That is the blood pressure of roughly a normal, healthy human being, 120 over 80. When you're looking at the 120, this is the systolic pressure. The one on the bottom is the diastolic pressure. When you're talking about the systolic, you are talking about the contraction of the ventricle, which means diastolic is the relaxation of the ventricle. Ventricle is the one that's going to push everything out. So that's what I'm going to concentrate. I don't really care about the atriums. I care about my ventricles. The other way you can look at this, and when I get back to class, then we're going to do this. Your systolic pressure, or the contraction of the ventricle, is also the first sound you hear within a stethoscope. And then the last one, the relaxation, the diastolic, is going to be the last sound that you hear in a stethoscope. So hopefully you kind of followed where I went with this. They all followed one after another. So technically, 120 over 80 is going to be a normal blood pressure. That's going to be your systolic over your diastolic. Systolic is the contraction of the ventricle. Diastolic is relaxation of the ventricle. Or if you're looking at it from the stethoscope point of view, then you're talking about the first sound over the last sound. And that is how you take a blood pressure measurement. With blood pressure, two things I want to talk about are hypotension and then its counterpart, hypertension. Hypo means you have low blood pressure. Your BP is fairly low. This means that your systolic is below 100. After my grandfather had his heart attack, he was always known, my dad's side of the family actually has pretty low blood pressure, and I usually fall in line with them. My grandfather had hypotension, and so he had to wear certain compression socks, especially as he got older, because also your blood doesn't flow as well. Yay for getting older. Had to wear special socks on his legs to help keep his blood pressure from bottoming out, and sometimes he would just faint because his blood pressure was so low. One of the disorders that you can have from hypotension is something called orthostatic hypotension. This is when you have low blood pressure and dizziness. And this is what my grandfather had. So this is mostly going to affect the elderly. It's not going to be one that's going to affect you, but one day you might get to experience this one. The reason this happens is because blood pools in the extremities. So your arms, your legs, and when you get up, all of a sudden, when you rise from a sitting position, your blood pressure just drops and you end up being either very dizzy or in some cases you might faint. Now the reverse of that is hypertension, which my mom suffers from this. However, not so much since she retired from teaching. This is when you have high blood pressure. It can be transient, meaning it's kind of an adaptive thing. You adapt to your environment. So say you're in a high stress level situation. You're running from a bear. I have no idea. You can have high blood pressure. So it's going to be more of an adrenaline type of thing. Or it could be persistent. If it's the persistent one, this is the one that you got to worry about. This is what my mom had when she was teaching. Her blood pressure was always so high. She had persistent high blood pressure and had to take pills for that. When it is persistent, you can have what's called chronic hypertension. This, unfortunately, is called or is known as a silent killer. As you get older, it is a very good idea to go and get your blood pressure checked often on those yearly visits when you have to go to the doctor to make sure that you do not have this. The reason it's called a silent killer is because it is asymptomatic. For the first 10 to 20 years. So you could have high blood pressure for a fair amount of time before you actually see any of the effects of it. What it does is it strains and damages the heart and arteries. When you damage your heart, what you're doing is you're increasing the amount of myocardium you have in your heart, which is not necessarily a good thing. When you increase your myocardium, it's because you're increasing how hard your heart has to work. Means you're making the muscles of your heart stronger, but it's actually going to start damaging your heart to after a while. There is a point where it is no longer good. If you're messing with your arteries, then you're going to have an increase in atherosclerosis. And this is when you have a hardening of your arteries and therefore they no longer work the way they are supposed to. Okay. Last part of this lecture is going to be the fetal heart. I'm going to start drawing mama's heart. So this will be mom, and then I'll put baby off to the other side. So draw a heart, just like what we've been doing in class lately. Go ahead and divide it off for me. However, make sure you leave little spaces in between so that we can talk about the valves. What I want you to add in is just the 2 major arteries for each side. For mama's heart, you're going to have the pulmonary arteries, and they're going to go off to your lungs. Over here, you've got your tricuspid valve. On the other side of your heart, you've got the aorta that is eventually going to go behind the heart and then come out the bottom. And you have your bicuspid valve. For these pictures, I'm going to be going back and forth between some slides because I'm going to run out of room. So I'm going to do everything for mom first, and then I'll come back and fill in baby stuff as well. So I just ended up with my descending aorta down here. If I'm looking at it from this side, eventually my descending aorta is going to give rise to my iliacs down in my pelvis. If you're a mama, you are going to have a placenta. Connecting from your kind of iliacs, you're going to have a vein that is going to go from one of your iliacs into the placenta. This is called your uterine artery. And what it is going to bring to the placenta is going to be oxygen. That's the main thing that you want. From mom to baby, you are going to have a connection between the umbilical cord. From this point, you have oxygen going to mom, and it is going to eventually, once it gets into baby, so baby's, this will be mom on this side, baby will be on this side. It's going to hook up to a very important vein that you already know about, and that is your inferior vena cava. And it is going to take it back up to the fetal heart. So you're going to have another heart over here. So do baby over here. And you're going to have that inferior vena cava coming up from the base and is going to carry actually oxygenated blood. Now, in baby's heart, you're still going to have your tricuspid that will form, and you'll have your bicuspid. Still going to have both of those. Within a baby's heart, you're going to be missing a couple of things, though, or you're going to have the addition of a couple of things. So leave a little space between the right and left atrium as you go through and draw this. You're still going to have your pulmonary vein. It's still going to be there. It's just not going to do the job that it does for you right now. You're also still going to have your aorta that is eventually going to drop back down. Here's one of the kickers that's going to be new for the baby. And then this, that opening I had you leave, is also going to be something unique to the baby's heart. And I'll come back and label all of those in just a minute. If you go back to the other one, coming down, you're going to have all of the normal ones. So this is going to be your descending aorta again. It's going to eventually branch off into your iliacs. And eventually you're going to send everything that the baby doesn't need back to mom. And it's going to go back to the placenta, where it will get then picked up by another very important thing and taken back to the lungs so it can get recharged, and that is your uterine vein. These things right here, both of these, are your umbilical arteries. And they are bringing, of course, deoxygenated blood back to this placenta so that it can get picked up by the uterine vein, and so then it can get hooked back into the inferior vena cava and taken back up to the heart and to the lungs to get refilled. This one, the one that's connecting mom to baby and taking oxygenated blood, is called your umbilical vein. And this is going to carry O2 blood. So that's your basic drawing. Just to kind of look back over it, mom, you already know everything she has. She has her pulmonary arteries. She has all of the AB valves, all of that, descending aorta. When you get down into the pelvic region, you're going to have a special artery that's going to hook onto a placenta, and it's going to bring oxygenated blood to the placenta. That is then picked up by the umbilical vein, transported through the umbilical cord, where once it reaches baby, then it's picked up by the inferior vena cava and taken up to the heart. Once it reaches the right atrium of the heart, it will kind of go through a circulation, but not entirely. It will go through the right atrium into the right ventricle, and it'll go up into the pulmonary arteries. However, everything pretty much skips the left side of the heart. You'll see that I have a connection between the pulmonary arteries and the aorta so that you have this interchange right there. So for a baby, I don't really use the left side of my heart. That blood will then get pumped over to the aorta. It'll get taken back down to the lower extremities of the baby through the descending aorta. It'll get picked back up by umbilical arteries, taken back through the umbilical cord to mama, to the placenta, and then picked up by the uterine vein, which will then eventually hook up to the inferior vena cava and take it back to the heart and the lungs. Okay, so that's basically how it works in the connection between mom and baby. It's all about the placenta, the umbilical cord, and then how it gets through one side to the other. Now, you'll notice within the baby's heart, there's a few things that aren't there anymore. If you compare mom and baby, the heart of a, out of the womb person and the heart of someone that lives in the womb, you've got some pretty blaring differences. One of them, I'm going to label it as number 1, is that connection between the pulmonary artery and the aorta. Second one is going to be the big hole that's between the right and left atriums. And the third one is actually the connection that's going to take the umbilical vein to the inferior vena cava. These are all big difference, and there's a few more, but these are the ones I'm going to focus on. These are the big differences between a adult heart and a fetal heart. First one is called the ductus arteriosus. What this one does is it transfers blood directly to the aorta from the pulmonary trunk or the pulmonary arteries. When the baby is born, this will shrivel up, and it becomes known as the ligamentum arteriosum. And you can still even see evidence in this in a human. It's pretty hard to find, but you can still find the shrivel up version of this that would connect those two things. The second one that I labeled is known as the foramen. Gee, where have we heard that before? Ovalis, oval opening. Wow, amazing. This one allows blood to pass between atriums or atria. When the baby is born, this gets filled in and it becomes a fossa ovalis. And basically you can still see this, and what you would see is a shallow dent in that arterial wall. The third one that I had you labeled is called the ductus venosum. This connects the umbilical cord to the inferior vena cava. When the baby is born, this becomes the ligamentum venosum. And you could still see evidence of that, but that one also, just like the ductus arterius, when it becomes the ligamentum arteriosum, it becomes very hard to find. Okay, so those are your major differences between a mommy heart and a fetal heart. I'm so sorry that I couldn't be in class today, but hopefully I will see you on Thursday and we will get to do these sheep heart dissections. Until then, I will see you all later.